Very good evening to all of you doctors. Warm welcome to the series of the Nova Journal Club webinar. This is the third webinar, in fact, after we started this series in the recent past as a mark of celebrating our 50,000 plus successful IVF pregnancies. In fact, while we are doing the series and the third webinar, in fact, our pregnancy is already crossed 53,000 plus while we are being on this campaign, right? Dear doctors, since the inception, Nova has always set the gold standard in IVF in practice, transparency, and ethics. And we were absolutely been on the core practicing or following the ICMR guidelines then, and then now the current ART Act as well. And we at Nova always believes in engaging our referral doctors academically. And this webinar is been aimed towards that, so that you and Nova IVF as a partner together, realizing the parenthood dreams of the infertile couple. Today's webinar of the topic is most interesting topic one, because ever since the 2022 ART Act came, there is a lot of ambiguity about the practice of an IUI ovulation induction by the practicing doctors, and what is the level which they can able to manage the patients, where they need to get a tie-up with the doctors, where they need to tie up with the level 2 clinics, and a lot of ambiguity regarding this, right? And today we have the eminent faculties across the country practicing from different part of a Nova centers, trying to disseminate that and helping you all to understand the way what we are supposed to engage and the way we can able to practice IUI in the era of an ART Act. So it's my pleasure to introduce our today's moderator, Dr. Sonia Malik. And of course, I mean, today's moderator and the panelists of the eminent faculties have been not requiring any kind of an introduction. In the interest of a time, just a brief introduction to all of you. Dr. Sonia Malik is having 3 decades of an experience. He's our program director for our Nova IVF South End for the entire Delhi NCR. And we have with us Dr. Roit Gutgutia, is another panelist who's been the medical director for Nova IVF Kolkata. And we have Dr. Aviva Pinto, who's been a practicing senior consultant at Nova IVF, Basaveshwara with about 25 years of an experience. And Dr. Ajantha Boopathi is another senior fertility specialist practicing at Anna Nagar at our Chennai branch. He's got about 14 years of an experience and the CCT certified clinicians. Dr. Aswati Nair, who's been practicing fertility specialist at our Azuri Garden Delhi branch with almost 14 years plus experience, special interest in endometriosis and the recurrent IVF failure. And another panelist, Dr. Sandeep Mane, a fertility specialist practicing in Thane, Nova IVF. And yeah, of course, he started kind of a Susanvan Abhiyan in association with the JJ Hospital, Mumbai, has trained many doctors in terms of laparoscopy. And the last but not the least, Dr. Sujatha R is our head of embryology at Nova IVF, who's got 26 years of an experience and held a position as a IVF lab director in many reputed institutions across the country. So come on, doctors, let us try to understand what has been the ART Act means to a practicing gynecologist, practicing IUI in the era of an ART Act. So over to you, Dr. Malik, ma'am, please. Dr. Malik, ma'am. Ma'am, you are on the view.
Yeah. I'm sorry. Yeah, I was asking for permission to share the screen.
Yes, ma'am.
1 second. I hope you can see the screen now. Yeah, I think.
Yeah.
Yeah.
Yes.
Thank you for setting the stage for this very interesting webinar. And I think we all, a very good afternoon to all my panelists and to all those who have logged in with us today. I think we all, ever since this gazette came in, ever since we had the act in December, followed by the rules first in March and then in July. We've all been rather confused as to what we should be doing and what should be our next way of practice. And that is why, as Mr. Selvam said, there's a lot of ambiguity also in the Act, and we are actually nonplussed as to what we should be doing. A lot of chaos everywhere, confusion. Everyone is just doesn't know where we stand and what we need to do, especially the general gynecologist. The level 2, as they have said in the Act, are still okay because they understand that they have to continue to do IVF. But what about the level 1 or the ones who are supposed to be general gynecologists who are doing up to IUI? That is why we chose this subject. And before we go ahead, let us just analyze this Act a little bit and see what it has in store for us. So if you do a SWOT analysis, we see what are the strengths. It is actually aimed to regulate the ART scene in India, and it is supposed to be weeding out the illegal players. Stop unscientific and social practices, and better governance should come in. The opportunities that it gives us is basically consolidation of practices with more numbers to treat, obviously, and an opportunity for research also, because then we are consolidating. It does have weaknesses because it has ambiguities and the implementation is not proper, as we can see. And of course, we feel that it is not patient and doctor friendly at the moment. The threats, of course, are that we do need to have strict data management. There is severe punishment, and third-party reproduction can go wrong, awry, unavailable also to those who need it, the poor class, where it may become non-affordable. So these are some of the problems that we can have, and of course we have strengths. So our aim today is to make use of these strengths and look at the opportunities and see how we can, address it and make ourselves much more happy with what we have got in this Act. So let us just try and see what it means to be a level 1 and what is actually defined. So in the notification that came in March 22, so they said that the level 1 ART clinics would be where the preliminary investigations are going to take place, including diagnosis of type, cause of infertility, and basically simple parts of only IUI can be carried out as a part of treatment. However, it was less clear in the notification that came out on June 22. This one was not gazetted and this one is gazetted. So this is what is going to be primarily important for us, where only IUI procedure is going to be carried out as a part of the treatment. Of course, the investigations and diagnosis still become a part of it. So essentially, it is extremely clear that only up to IUI is going to be done by these clinics. So how do we position then IUI in this era of IVF? How do we do it? We know that in India, price is a major factor, and it is one of the factors which actually determines which way the patient wants to go. And therefore, IUI is actually a very important procedure for all of us. It is a primary procedure which every patient always looks up to because it is simpler, it is shorter and easy, it is cost effective, and it is less stressful. Only thing is that the patient has to be selected carefully. Whereas in IVF, it can be anybody can go through an IVF. There are so many indications for it, but of course it has its own problems. So that is why, even though IVF is becoming popular everywhere across the world, IUI still holds good in India. So let us just start this thing by asking my panelists now, how do we want to position this in our country and in the perspective of this new act that is coming? So as a first-line treatment, we are always advising IUI. However, the indications and the success rate of this procedure is seldom discussed with the patient. So my first question would be to Dr. Ajantha. What are the indications of IUI as you see it? What do you think how should we be looking at it?
Thank you, ma'am. So the IUI is indicated in couples with unexplained infertility, mild male factor, minimal endometriosis, and cervical factor infertility, and in women who have ovulated dysfunction and ejaculation dysfunction.
So basically, yes, most of the guidelines of all the different countries, unfortunately, we don't have any Indian guidelines. Of course, Nova does have its own guidelines, but we would stick to the society guidelines from across, and all of them do point out to unexplained infertility, mild endometriosis, and male factor. And therefore, that is supposedly what we are also trying to do. Then what is the success rate of IUI? May I ask Aswati?
Hello, ma'am. Thank you. Thank you for the question. Good afternoon. The success rate of IUI, it's something which is very important as a clinician also to understand, and also for the patients. The success rate could range from anywhere between 9% to a maximum of 25%. In unstimulated cycles or in cycles where just ovulation induction drugs are used, probably the success rate could be somewhere between 9% to around 13%. But if gonadotropins are used and where multifollicular growth is expected, the success rate could be expected to be much higher. It could be as high as 25%. But it has to be brought to the patient's notice before the start of the treatment cycle that this is what they should expect from the procedure.
And does it improve with these, as you go on doing the cycles? Is there a change? Is there a cumulative pregnancy rate also with number of cycles?
Yes, cumulative pregnancy rates could rise because, as I believe that, every attempt of treatment that you take as a clinician, also you start and modifying things up to, certain extent. And that, of course, can increase the cumulative pregnancy rates. So that is why when we talk about IUI, a maximum of 3 cycles is what we recommend to all our patients. And if at the end of 3 cycles also they don't conceive, then it is better to stop and introspect what is going wrong. And maybe IUI is not the treatment for that.
Does it change with the kind of indications that we talked about? Is there a change?
Yes, absolutely, ma'am. Yes, absolutely. For different indications, the success rate could be different. As far as the success rate is concerned, the maximum success rate, of course, could be in mild male factor infertility, whereas in unexplained infertility, minimal to mild endometriosis, where you have bilateral patent tubes, the success rate could be much higher than where you have a unilateral patent tube. So, all these factors could determine the success rates of IUI. And again, one more thing is the age of the female patient, because we see that IUIs are being randomly done even at extremes of age or advanced maternal age. Of course, the success rate wouldn't be in this bracket if we are doing it at that age.
Absolutely, absolutely correct. So then as you mentioned just now, there are factors which are going to affect the success of the IUI. So then, Dr. Aviva, what would you think about these factors? Can you just outline some of these factors which are going to affect our success rate in IUI?
Thanks for the question, Dr. Sonia. Like Dr. Aswati said, one of the most important things is the age of the female partner. We know that as the oocytes age, there is more likelihood of being aneuploid oocytes, which may not translate into a pregnancy. Of course, the most important factor continues again to be the quality of the semen. Arbitrarily, the total normal motile sperm count post-wash should be at least 5 to 10 million. All the time, we do see patients who have had IUIs with sperm counts of less than 1 million, 2 million. So it's very important to decide which patient goes for what treatment. Again, tubal factor, at least one patent tube, and the number of IUI treatments, like was mentioned earlier, would also indicate whether we need to move on. 60%, as it is, the success rate is low. It's only about 15 to 20%, and 60% of those pregnancies will happen within the first 3 cycles. If not, I don't think it really would go up. The important thing again is whether it's an IUI in a stimulated cycle or an IUI in a natural cycle. There is quite a big difference in the success rate. Then the timing of the IUI. All the time we have patients who come in within 24 hours of the trigger, or sometimes 3 days after the trigger. So this is something that, we really need to take cognizance of, and have the patient come in at the correct time, ideally between 36 to 40 hours. And again, have the semen processed in a fertility center. Semen processing in a lab as against in a fertility center, there is a world of difference. So these are
I think we'll ask Sujatha for this, but of course, like you're saying, all 3 of you have said the same thing. Despite the fact that IUI has been the prevalent method of fertility treatment in the country, and practically everybody is doing IUI, we still are not very clear. We still are not very stringent of the criteria, and we are still lagging behind as far as working up of the patient is concerned, and therefore the success rate is minimal as well. So now I think this is basically for you, Dr. Sujatha. As Dr. Aviva said, do you think a proper semen analysis could be the answer? Are the reports generating from IVF labs different from the normal path labs?
Thank you very much, ma'am, and good afternoon, everybody. For the first question, it's an absolute necessity to have a proper semen analysis, because semen analysis forms the basic test of any infertility workup. So hence it's very important. And why is it the semen analysis done in an IVF center different from the normal path labs is because IVF center, they actually stick to WHO way of reporting semen analysis. And even the checking, Mechler chamber is used, hemocytometer is used, number of sperm counted would be whatever is mentioned in the WHO manual, and the reporting would be like that. This actually would give an idea to the consultant whether this patient is suitable for IVF or for IUI. For example, if you're talking about just motility, it's not enough if we say that the motility of this particular sample is 40%. We have to say what is the rapid progressive motility, because for an IUI sample, it is an absolute necessity that the rapid progressive motility should be high. And similarly, when we say normal and abnormal forms, what kind of abnormality has to be mentioned in the report? Because suppose if the sample has a lot of abnormalities with the head, then, that sample is not fit enough for an IUI insemination. So all these things make a good semen analysis a very important contributor for IUI success.
So then we come to this very, very pertinent question. What about the manpower then that would be needed in a lab, and how important is the qualification of the androtechs and the training and validation? And do you think there should be very stringent SOPs even in an IUI lab?
Okay, ma'am, regarding the manpower needed, I have to first mention the unfortunate scenario in our country where we do not give any importance to sperm preparation. In fact, in majority of the labs, if you observe that you can see the new person, the least experienced person would be given work in the andrology laboratory. Elsewhere, andrology or semen workup is supposed to be, it falls in the high complexity lab. So, this is a very important point that we have to pay attention to sperm preparation, because gone are the days when we thought that the role of sperm is just to give the DNA. It's much more to it. It's a very significant contributor to a success rate in any ART technique. So hence, the manpower needed, actually we need a qualified person. Again, there is no specification mentioned in any of our laws or guidelines, but like from whatever I have seen from the education status in this country, we expect people to have at least a postgraduate degree in biological sciences, or if they have this diploma in medical lab technology, they should have few years of working experience in a clinical laboratory. That is very, very important. And not just the educational qualification, I think, the candidate should also be interviewed for other skills like cognitive skills, communication skills, because working in an andrology laboratory, it involves a lot of communication with the consultant, with the embryology laboratory. So all these things also have to be looked into. Then validation. How do you do validation? Because normally training is done there. We start with beads. Many labs do not have the facility of, validating or training people with microbeads. In that case, we use the sample which comes for semen analysis. The leftover sample is actually used for training newer candidates. And validation, what happens is initially they count side by side, and then we let them count more than 30 samples. And the difference between the counting by a senior person and the person who has joined new should never go beyond 5%. When that stage is reached, the person is validated. Like that, the validation is done for all parameters, not for just count, motility, morphology, sperm preparation, and all the procedures involved in an andrology laboratory. Now, the third question, SOP, this is very, very important because SOP actually allows us to have a standardization in the laboratory. If you do not have SOP, then every day the sample preparation actually can vary. To avoid that, we have this SOP. Now, when we say SOP, it should have every single detail, including what kind of equipment is needed, how do you maintain the equipment, what kind of quality control will you do in an andrology lab, and then how the procedures. It's just not simply you write the procedures, the reason, the principle behind it, and then what happens when there is an unusual situation. Say, for example, a patient, like usually the sample volume is somewhere between 2 to 4 ml. If you get a sample whose volume is less than, say, 0.1 ml, or if it is more than 7-8 ml, how would you process that? So such unusual situations will also be mentioned in the SOP, what you should do. And, these things will be completely written. And following that actually would give us a very standard way of sperm preparation, which contributes a lot to the outcome. So SOP is very important, and following SOP is also very important.
So I think, Dr. Sujatha, you really have given us a wonderful insight into what you should be having in an andrology lab. And I don't think people are taking it that seriously at all, especially where IUI is concerned, because everything is being done in path labs. So basically, this is a very, very important point that every one of us who is attending this webinar should understand, that this is a procedure which has to be taken with great dedication, I think, and done properly. Only then can you get the desired results. So we shall come back to you soon after this again, Dr. Sujatha, for some more insight into this. So now we know that these are the tests that are going to be, that we are wanting to do: the ultrasound to see that the uterus and cervix is normal, HSG, SSG, husband semen analysis like we've discussed, and ovarian reserve and ovulatory status. So Dr. Rohit, now are you doing all these tests in the first go only, or are you reserving them for staged wise? Say first cycle you will skip the ovarian reserve testing, second cycle you may do the testing for the tube or things like that. Is it what you do, or do you think everything is essential and you should do it before you start taking a patient for IUI?
Thanks, Dr. Shone, for this question. Taking a cue from what Dr. Sujatha has told us, and Aswati has told us, and Dr. Aviva has told us, I would like to answer this question in a different way. I would say it's a not. So do not do an IUI if you're not sure about the uterus and the cervix. Do not do an IUI if you do not know the patency of the tubes. Do not do an IUI if the semen analysis is not within a defined parameter. And do not do an IUI just because the sperm counts are very low, because we tend to think that IUI is a very simple treatment. But as you pointed out just 2 seconds back, that just because it's simple from the clinician's point of view, we should not ignore that it is not simple from the patient's point of view. And if she fails a cycle, she develops a negative idea about the whole process, and she should be very clear that she qualifies for an IUI if she is to be taken for an IUI. And this is where the last point comes in, that you should also look at the ovarian reserve before, and the age of the person, before you counsel her for an IUI, because end of the day, again, another not, 92% women are not going to get pregnant in this particular IUI cycle. So I should be prepared to counsel her before the cycle, so that we can have her come back for the second cycle. IUI or IVF is a place where we have to do multiple cycles, and we should not look at counseling for one cycle. And for that, all these nots have to be kept in mind.
Thank you. That was really, really very clear and crisp. Yes, we have to say no to many things, and no to ourselves also when we are deciding what to do to the patient. So now, when would you consider IVF after an IUI, or when would you straight away ask her to do an IVF, Dr. Rohit?
So, yeah. So again, one of those tests that we carried out and did not come across as a good test, I would have recommended an IVF. To be specific, if the female is more than 38 in Indian scenario, I would strongly suggest that she should move on. If she has failed 3 or more IUIs in a good center, when I say a good center, that center complies with everything that Dr. Sujatha pointed out. Again, re-emphasizing, the IUI may be a simple procedure from the clinician's point of view, but sperm preparation is definitely not simple, and the sperm preparation has a lot to play in success rates. So it should have been done properly. And then, of course, if the tubal patency is doubtful, then I would recommend. Years of married life is not so important in my counseling. I would rather look at the active time that they've been trying for. And if they've been trying for more than 5 years, then of course, counseling for an IVF is important. The NICE guidelines talks about offering or recommending an IVF treatment after 2 years of trying time, but that's something not really into our practices yet, but that's also something that I like to point out to my couples once we are counseling them about transitioning to an IVF cycle.
Okay, thanks a lot for that. And then we move on to the failed cycles. And I now ask Dr. Sandeep, what is the role of endoscopy if your IUI fails? Or would you like to do a laparoscopy in the first sitting, just when you're recruiting this patient for an IUI? Would you want to do it then, or would you want to think about it when the IUI fails? When would you do a laparoscopy or a hysteroscopy, if that, for that matter?
Yeah, thank you very much, Dr. Sonia, for the question. As everybody knows, that a couple who comes to us for any form of help is really not happy. They are not really wanting treatment, to be honest. So they're trying to keep it simple. So initial, like Dr. Rohit pointed out, blood test, semen test, blood test sonography, AMH, and the baseline testing is fine, acceptable, with reluctance, but they're ready for that. But they don't really want an anesthesia. They don't want a surgery. And that's something we are trying to avoid for a phase 2 of treatment if we are unfortunately going to need to go further than that. Now, initially, if you do a sonography and find a fibroid or a polyp or some sort of a problem, then there might be indications for doing a laparoscopy even before you do an IUI, because there's something rather obvious like a blocked tube or something like that, where you want to check the tubes, open the tubes, and then do the IUI, which might make sense. Now, to all the gynecologists who are listening to this webinar, the most important thing is to counsel from day one. From day one, from the time you see AMH, the tests and all that. So you can mentally prepare them that look, if we require, we'll do IUI. If we require, we'll do laparoscopy. And if required, of course, down the line, IVF may become necessary. So we need to share that information from day one, rather than us breaking it like a big bad news one fine day. So when we do laparoscopy, one thing to reassure the patients is like, it's more like a daycare. You're coming in the morning, going home by evening, no cuts, hardly small 3 millimeter cuts, no scars, and that helps them to accept that. At laparoscopy, when we do it, let's say, for example, like Dr. Rohit said, 3 good IUIs in a good center, and we still are unsuccessful. Yes, patients are mentally now ready to take a laparoscopy. And when we do a laparoscopy, we're checking the cervix, the uterus, in hysteroscopy as well, and then the tubes and ovaries, and clearing everything and improving the chances. Now, this is the time to counsel the patient. Look, the laparoscopy is normal, which is good. So let us give it a try for another 3 more IUIs. If not, then IVF. Or laparoscopy is a problem. There are a lot of adhesions. There's tuberculosis, endometriosis, and more IUIs may not make sense. This is how we help the patient to come to a decision. And if we involve and share this information, laparoscopy has a huge role to play, not only in improving the success rates of IUI and avoiding IVF, but even if we go to IVF ever, unfortunately, then there is so much preparation that the laparoscopy and hysteroscopy has done, which enhances the outcomes of IVF. And that's why in our sort of centers, we have such better results.
Thank you. That was really clear. And as you can all those who are listening to us, you can see that all my consultants are actually emphasizing a lot on counseling the patient. The patient has to be counseled right from the time she steps into your office, and you have to keep on doing it repeatedly, no matter how many psychological counselors you may have in your clinic. The clinician has to talk about all aspects of every treatment that he or she is giving to the patient. So that is very important. And so also, we sometimes neglect the embryologist and we sometimes neglect the lab, but the lab scientist must also face the patient. The patient must know that there is another person who's working behind the scene and giving us the kind of results that we want. So basically, all of us working hand in hand is important, and that is how we get good results in any procedure that we do for infertility. So let's move on, and we can kind of see that what is happening is total confusion. Like I said, there is poor workup of patients. Less than 50% of the gynaes are doing the entire procedure under one roof, which is very sad. They are sending patients to ultrasound labs and path labs, poor semen collection and analysis with facilities in the path labs. Semen preparation is done in distantly located labs, and therefore there is a lot of delay in the IUI procedures. As I think Dr. Aviva Ajantha pointed out, patients are reaching many days after the trigger has been given, or maybe just before that, because they are far away from the facility. And so therefore it is leading to poor outcome and patients are also suffering. So let's move on and see what we can do. What does the Act now tell us? What are the proposed changes in this in the IUI practice? What is mandatory, Dr. Sandeep? Let us just get on to business now.
Yes, we've been talking about, thank you for that question again. We've been talking about the various problems that we've been facing. Doctors have been facing, patients unfortunately having to suffer over the years. And these guidelines have been in the process for a very, very, very long time. And everybody's realized that this had to come to kind of make it better and get regulation. What they have got in mind is that they needed to structure the whole care for fertility patients in different levels. So level 1 is a basic level IUI kind of facility where there will be a gynecologist who will be kind of a qualified postgraduate doctor. And with the gynecologist, the other requirement is the minimum equipment, which is a refrigerator, a microscope, and basically a centrifuge. And of course, there is a need to do data keeping, in reporting to the authorities. So there is this that they have got as a level 1, which most of the gynecologists would be involved in. Of course, the level 2 people, like you've already pointed out, are doing the IVFs, and that's okay for them. But for ART Act level 1, this mandatory registration is a law right now.
Yes. So basically, yes, we do see some kind of a regulation now coming in. But now let us discuss the various scenarios that our doctors may be facing when they are challenged with this new kind of act, wherein there has to be a lot of regulation over here. So let's see what are the funny or a little difficult situations that we may have when we are doing this kind of a practice. So let us take the first clinical situation now. You are a postgraduate and a 38-year-old patient comes to your clinic with a complaint of infertility. On questioning, you find that she got married just 6 months ago, but is in a hurry to have a child naturally. Cycles are regular, but no other investigations have been done. So now in the current scenario where you have the act in front of you, what can you do for her? And I think Dr. Ajantha has been quiet for a long time. Why don't you answer this one?
Thank you, madam. So as she's 38 years old, for her, the infertility evaluation treatment is indicated. So I will do an ultrasound to check the antral follicle count, rule out adnexal nutrient pathology, get a AMH to assess the ovarian reserve, and we have to get a tubal patency test, and also the husband semen analysis. And I will counsel her that female age is the single most important predictor of fecundity, and the female fertility declines with the advanced maternal age. So we all know that over 38 years of age, the pregnancy rates and the live birth rates are better with IVF than with IUI or expectant management. But again, I have to discuss with her the options based on the results. So in case if she is not willing to go for IVF, if she wants to try IUI, as a postgraduate gynecologist, if I am not applied for level 1 registration as a level 1 ART clinic, I would not be able to do IUI for her. In that case, I should refer her to a level 1 or level 2 ART clinic. In case if she is willing to undergo IVF treatment, then I would advise her to and refer her to a level 2 ART clinic.
So basically your function over here is to counsel, and then second to do the basic investigations for this patient in order to actually outline her further treatment management, right? So that is all that you can do when you are not registered as level 1 also, right? The only thing is, where are you going to do the semen analysis now? My pertinent question here. You are not supposed to do it, but where are you going to send the man for a semen analysis? A path lab or a level 2 clinic? Where would you prefer?
It would be better to send to level 2 clinic, ma'am.
Yes.
As the assessment would be better.
We've just heard Dr. Sujatha, so I think we should start learning from there. Instead of sending patients who are suffering from infertility to path labs, we should try to send them to level 2 clinics now in order to get the right assessment. So now we are finding that most of the gynecologists are not registering for level 1 ART clinics. Why do you think there is this reluctance, and what are the practical problems of doing IUI in a level 1 clinic? I looked at the portal and I found that only 196 clinics have so far been registered, out of which only L1 is only 34 and L2 are 162 in this huge nation. And there have been no rejections till now. A total of 400 and something have applied for level 1. So that means that most of our doctors are very reluctant to even, apply for getting this status of level 1 ART clinics. So why do you think that is so, Aswati? Why do you think we are having this problem?
You, ma'am, actually very rightly pointed out that gynecologists are reluctant to get their clinics registered as a level 1 clinic. First of all, there are various aspects to this. First of all, the mandatory registration process that they have to undergo. A mandatory registration fees of 50,000 rupees that they have to submit to register themselves as a level 1 clinic, which has to be renewed every 5 years. Secondly, a strict data management and record keeping has to be done as per the law. And, you know, of course, as we know that any kind of discrepancies, if found by the authorities, the gynecologist would be could be penalized for that. So that again is a scare in most of their minds. Plus, you know, after going through all this mandatory registration process and the data keeping and everything, the cost of IUI for a patient would definitely increase. So that was one thing that always differentiated IUI being done at a local gynecologist clinic and one at an IVF center. Patients always point that out. We are slightly overpriced because probably we have been doing this right from the beginning, even before the act came into existence. So yeah, this is another thing that the guy, because they would have to have extra manpower, extra, lab setup to, you know, prepare the semen sample at their own clinic, which would enhance their results. So all these could bring about an extra cost of treatment, which of course would be an increase in the price of IUI at the level of the patient. So gynecologists are, considering the cost benefit ratio also, they are kind of deterring themselves from getting registered as a level 1 clinic, in my opinion.
So yes, I think you've really hit the nail on the head, you know, so I think it is that. And but the question is, if they don't practice as level 1, are they not going to have many problems in treating infertile patients? What is going to happen to the huge bulk of infertility patients who are not ready to go in for IVF, not ready to come into the level 2 clinics, cannot afford the level 2 clinic treatment? What is going to happen to them if gynecologists do not register for them? Let us take the next situation and try and understand how we can best help our own colleagues by doing what they want to do, yet are not wanting to register and go ahead with what the ART Act is saying. So here is the challenge, therefore, is, first of all, let me first sort out the, the challenge of the lab. As you said, the lab is going to be a major challenge. Now, Dr. Sujatha, and Androtech is not mandatory staff in level 1. We don't have this written over there that you do have to employ a highly skilled technician over there. So semen wash can only be done in the premises of the clinic. So they cannot ask the path lab anymore to do it. So do you think the gynae should be doing semen analysis and semen prep themselves, or they should still be hiring a technician? What is your take on this? What do you think as a lab person? Do you think they should be doing it themselves, or would you be able to train them to that extent that they are perfect in it, or would you still want to hire a technician over there?
Ma'am, according to me, sperm preparation is just not a one-time procedure. It involves a lot of before and after stuff. Like you have to maintain the lab, you have to maintain the equipment. The fridge temperature has to be checked every day. The air quality has to be checked every day. You should have a laminar airflow. So I feel that there should be a dedicated person to do that. Because if it's just not, you get the semen sample, you process it, and then you do insemination. Now, whatever the consumables which we are getting, we should look for toxicity. And, you know, anything which comes into contact with the sperm should be evaluated for toxicity. So this is a whole lot of process there. So I feel that there should be a dedicated, trained person in the lab. Even if they are just doing very few IUIs in a month, still there should be a person available there.
So she has made it absolutely clear that this is not our cup of tea as gynecologists. We do need somebody who should be very well trained. And if we have to bring up the standard of care in infertility, we better behave and start employing people who are well trained and can really deliver the results. So thank you, Dr. Sujatha. I think we can move on to the clinical part of it again and see, now what happens is, this is the next challenge to Aswati. The same gynae realizes that she must register as a level 1 clinic because now she's understood that she has to do something and she has to practice basic, what is happening? Unfortunately, her workload is not much. That is probably the reason why she was a little skeptical about it. But she has a substantial number of infertility patients, but she has only 4-5 IUIs in a month. So you are her friend and she has come to you and asking you for advice to help her. Now, the various options are, should she register as a level 1 doctor herself, or should she register her clinic, or just refer the patients to you?
Depends on what she wants, ma'am. If she wants to go all the way and conduct IUI at her clinic, she should rather register herself as a level 1 clinic. As far as law goes, there is a lot of ambiguity still, whether, a level 1 clinic or, a gynecologist who's practicing in her routine OPD, whether she can do ovulation induction, whether she can do ovulation induction just with drugs, whether she can use gonadotropins at her clinic. So this is all ambiguous as of now. So maybe in the coming times, the law will be more clearer on this. Apart from that, ovulation induction, and if the clinic has a PCPNDT licensing, then probably follicular monitoring can be done at her clinic by her own. And then in that case, she can refer the patient to me. Of course, as her friend, I would request her to refer them to me for the procedure of IUI. But it all depends on what the doctor thinks, because 4 to 5 cycles, the main thing here is the cost benefit ratio that the gynecologist would get. And I would like to assure her that, of course, IUI in the setting of an IVF or a level 2 clinic, the results would be, I would assure her, would be slightly much better than if she does it at her own clinic. Absolutely. That I can assure her. And secondly, just talking out of the box here, but Nova's SOP being that we don't do any obstetric practice, her patient goes back to her as soon as she conceives.
Yeah, that's very important, Ashwati. That's very important. Yes, yes.
Yeah, that's very important, because most of them have this scare of losing their patients as well. So there could be a reassurance from our end that the patient goes back to them as soon as the pregnancy is done. And
wouldn't you want her to associate as a level 1 doctor in your clinic with you in level 2? Isn't that a possibility also that will make her a part of your team also?
Yes, ma'am. If she wants, she can, associate with us for her IUI. So, she can do the monitoring part and everything at her clinic with her PCPNDT licensing. And just for the procedure, she can enroll with us for the IUI thing. And she could bring her patients here to the clinic. And then she can very well do the IUI at our clinics.
Absolutely. That's a wonderful
We'll be happy to have her with us. Yeah.
Thank you. Dr. Rohit, this is a situation for you now. The patient, a gynae, has been stimulating patients for both IUI and IVF, and then taking them to her friends' IVF centers to perform the procedures. But she does not have the required prerequisite for qualifying as a level 2 doctor. So she has also not registered as a level 1 clinic, and her patients are sent to neighborhood ultrasonologists for monitoring and a path lab for semen preparation. So everything is outsourced. Can she continue her practice as such, or does she need to make changes? 1. Can the ultrasound lab and the path lab register for a license? Are these provisions for the same in the Act? Number 2, can she administer gonadotropins in a clinic? And do her patients need to register with an IUI clinic or an IVF clinic for the same? What are the various issues in this? How would you look at this situation?
Okay, so we'll have to go back as to why the law was framed and what is the intention of the law. So the law is trying to structure and streamline the practice of infertility. And that's something that we have to welcome with open arms, because that's something that was needed. There's no denying the fact that everything under the sun was happening and that should have stopped. And it's good that now there is an effort. And we've been doing this kind of webinars, quite a few of these webinars we've personally attended also for the last couple of months, where the consciousness is developing as to these are the things that we should avoid. So taking a cue from what Aswati told us, and I am a full-time fertility practitioner, my wife is a gynecologist, and I get into her mindset, and the understanding that I have from her is that they only want to extend their relationship with the patient, and which is why they offer an IUI treatment to their patients. So it's the relationship that they want to continue. So the best option for them would always be to associate or align themselves with the qualified units A, for the SOP, so that they get the better outcomes, and B, also because of the law suggests that. So if we really try and answer the questions in that context, it becomes very easy. She should not continue practicing the way she is, because this is directly contravening the law as it is today. And unless we have a change in practice, things are not going to improve. And one of the changes is that she should give up on practicing both IUIs and IVF in a not qualified unit, whether she is personally not qualified or whether the unit is not registered. As regarding the ultrasound lab and the path lab, I think we have made it very, very clear. Not only the legality does not allow that, also the morality does not allow that, because the trigger to insemination time is sacrosanct. And so also the ejaculation and the insemination time is also very, very important for successes to happen. And that can only be protected if the entire cycle is continued and concluded at the same unit. You cannot have a sample being given at some other unit, being processed there and then brought back, and the busy gynecologist finds time to inseminate the person also in good time. Does not happen in real practice. And all that you do is to create a bad name for the process, which is not fair to the patient, nor to the industry either. Can she administer gonadotropins in the clinic? I personally am of the opinion that she can, provided the prescription has been written down, the counseling has been done properly in a properly qualified unit. So long as the handling of the gonadotropin is concerned, because she's a medical graduate, she can. But there is a lot of ambiguity on this also. So I'll allow the house to come in, and if they want to comment, they can do that. And what is the best thing to do? By far the best thing to do is to send her patients to the qualified units, whether it's a level 1 or a level 2, to her liking, get them registered, have the proper counseling done in those units, and then handle the patient if she wants to in her own way till the cycle is concluded, but make sure that the law is respected.
Yes. So again, emphasizing, Dr. Rohit has very beautifully summed up the whole thing. He has emphasized on the fact that nowhere should this person forget that there is an act over there, that she's being regulated and ruled by something. So therefore, she has to make those specific changes. Now, I would just spend 2 minutes on each one of you to answer this question of administration of gonadotropins in your clinic, in her clinic, in somebody who's not registered, not even level 1. Should they be administering gonad? This is only your own personal opinion. I'm not talking about the act. We know it is ambiguous upon with us. I can see Dr. Aviva. Can you make a comment on that, Dr. Aviva? Somebody who's a postgraduate, and Rohit said, if she has a prescription properly written by a person. Now, how would you agree on? Would you agree on that?
Yes, if the patient has registered with a clinic, either a level 1 or level 2, if the gynecologist wants to stay in touch with the patient, and very often the patients themselves want to involve their gynecologist because probably they feel a lot more secure with them. They do go back to them every time we tell them something. If there is a prescription given by a level 1 doctor or a level 2 doctor to a gynecologist and they follow that prescription, I would have no objection to them, giving the gonadotropins in their clinics. But what really here I'd like to make a point is, ideally, if you have the PCP and DT license and you're doing your scans yourself, do it, or refer them back to the registered clinic for a scan, or have a conversation with your sonologist, because very often they report only the large follicles, and with those large follicles there'll be a lot of smaller follicles that could end up getting this patient into trouble and getting you into trouble if you ultimately do an IUI. So that is very important, not just monitoring, giving the gonadotropins, having a good scan done and every follicle that is growing reported.
Yeah, absolutely. Very, very wisely answered. Ajantha, what is your opinion?
Yes, ma'am. I think it's okay if the gynecologist would like to give the gonadotropins at the unit. The only thing which I would like to emphasize is the gonadotropins has to be stored appropriately in the refrigerator. Otherwise, the potency will be lost. So I think that part has to be informed, and the patients has to be informed that they have to take the gonadotropins on time if they are going for IVF stimulation. So they should not miss their antagonist dose. So yeah, and other things, as Dr. Aviva said about the scanning part, I think that's very important, where the scan findings has to be communicated with the doctor, the level 2 doctor, so that we can advise them the dose of medications, whether the step up or step down is necessary.
Absolutely, absolutely. So, Aswati, what about you? Your patient, this patient has not been shown to you at all, and they've been reporting only 2 follicles. And then would you like to call them once at least before an IUI, or you wouldn't want to call her at all?
I would really love to call her once, even though I would make a free consultation for the patient, but I would really want to call her once. So just as to get an idea of what it is about. Sometimes, you know, I mean, maybe she's not a very indicated or a selected case for an IUI per se. So I can probably stop the procedure right then and there and explain her the success. Because at the end, if I am doing a procedure for the patient, then I am accountable for the results.
Absolutely.
So, you know, just taking the accountability does not make sense. Rather, understanding things and making the patient understand and then taking the accountability makes more sense to me.
So you have to actually understand what kind of a person she is. The person who's referring this patient to you, is she knowledgeable enough about gonadotrophins or not? Can you trust her, and can you trust her ultrasound as well? So I left this question last for you, Dr. Sandeep, because you are coming from UK and you have seen the best part of it. You have seen the regulation and you have seen the nurses, really taking care of such patients. So tell us, would you trust gynecologists who are postgraduates and have been doing their own IUI practice in whatever manner? Would you allow them to administer the gonadotrophins and go ahead with it and come to your clinic and do an IUI?
Well, the question brings smile on my face because, Dr. Sonia, when you compare UK with India, you know, the traffic, the driving, the way things are on the road.
Yeah.
Achieved it over the period of years. And if I look at the Indian roads, and I expect everything in UK to happen here, then that's not going to happen overnight. So if I give that corollary, that where we are from, where Indian government is trying to get us to drive like the UK way of driving, I think we will get there eventually. But in that chaos, that slide, I remember the first slide that you put it, the chaos. In that chaos also, there were a lot of good gynecologists, senior gynecologists, who have done a lot of good work. And we can't underestimate them just because they don't have a registration. So I'm sure there are capable gynecologists who can do that. And as long as we are able to identify those people, and the law, I'm sure, is okay with that. It's the problem with the people who are not able to do, and they're doing all sorts of things. Those are the people we have to be careful and be able to select that. So ultimately, I think that's not a problem, certainly, as long as it is under our guidance. That's my point number one. And in point number two, I would just summarize in that the options available to all the gynecologists, basically, there are, I think, 3 options. One, to refer the patient directly and say, well, too much headache these days with all this law and the paperwork, and I can't be bothered. That's one simple way, and we are obviously going to be able to support them. 2 is where they feel, I want to be involved. I don't want to be cut off from my patients. So that involvement could be some sort of an attachment to the clinic, and they can come to us, we can guide them, we can support them, we can train them in various ways. And that will definitely be a win-win situation for the patients, firstly, and ourselves, as well as the intentions of the government. And 3 is, no, I just want to do my own work. Why would I give up? So I will go for the level 1 and I don't care whatever happens. Unfortunately, that will be a tough route, but that's fine. Some people might manage that, and we will always be there to support even them. So our support from Nova, kind of a leading national chain, will be on all these levels to help them to get the level 1 registration, to help them purchase the equipment, to give them the training for the...
We'll come to that later. We'll come to that. Okay. So basically, yes, everybody is of the opinion that yes, people can administer gonadotrophins, but of course, a little bit cautiously and carefully. So this is now eventually the same patient doctor decides not to register, but still wants to remain involved with the patient. I think we have half of it. We've sort of answered this, but anyway, how can we help her? She sends the patient to you on day 2 to us to register first after doing the required investigations, and then you set a protocol for her and send the patient back to her for OI. Are you right? Can she carry out the OI? What is the prerequisite for that? Would she be able to do that, Dr. Aviva? She has sent the patient to you to set the protocol, and she sent the patient to you for registration also. Now, will you like to do?
Yeah, I think it should be fine, Dr. Malik. We should be able to guide this doctor to do the IUI and the ovulation induction, but basically the patient has to come in and register with us probably on day 2. We do the scan and the protocol for the OI. And also, when the patient comes in, we need to make sure that they've had the required investigations.
Yes.
Semen analysis done, their AMH done, their, more importantly, tubal patency tested, all of that, and
That
then
she
sent
has
back.
done, that she has sent to you. She's done everything. If you can
Yes,
see it
then
on the
definitely,
screen.
yes, we
Yeah,
could
then she
have
can
them
do it.
register. Yes, we could have them
So what
register.
are these prerequisites that I'm talking about then? What are the prerequisites that I'm talking about then? I think she needs she at least needs a PNDT registration.
Yes, if
I'm
she's
not
going,
talking, yes, she needs
yes,
a PNDT because otherwise she will not be able to monitor this patient, right?
yes, if she's going to monitor the patient, then she needs to have a PNDT registration done, or else if she's going to be sending it to an outside radiologist, then she might as well send them back to us at the center to do the scan. She can administer the gonadotrophins at her unit. But ideally, if she's not doing the scans herself, the most sensible thing would be to refer the patient back to the IVF center, who is ultimately going to do the IUI for them.
Yes,
To the
absolutely,
center
absolutely.
where the IUI is being
Absolutely.
done.
So now, Dr. Rohit, this is a tricky situation. This patient, you have registered as level 1, and then you get a patient who needs a donor IUI. And the couple is insisting that his brother will be the donor. So first, is this allowed? How will you proceed? Will you outright reject this request, or can you do it under the Act? What are the criteria for the semen donor, and can you freeze the sample in your level 1 clinic?
Okay, so this is really a tricky one. And there's a lot of clarification that needs to be done, and some of it is not clear to me either. So all this while we were talking about anonymity of the donor being very, very important and has to be protected at every level because of the social conditions that we have been brought up in this country. Whereas rest of the world, again, Dr. Sandeep would concur, it has not been that anonymity is the most important thing. In fact, people were encouraged to get their own donors and get this done. So, however, now the law does not talk about anonymity. The word that has been mentioned is confidentiality. And when we talk about confidentiality, what we have interpreted, and this is semantics, is that it should not be leaked out of the clinic in any way. So that means you are eligible to get a relative or a known person to come and donate. So that's point. The problem is the level 1 is not required to have a storage facility.
Yes.
So because it's mandatorily not required, it's not required to have a storage facility. So you have to then find out a ART bank. As it is, all your donor cycles have to be routed through an ART bank. So the ART bank has the onus of screening and collecting the semen sample and storing it and making it available to the clinic as and when it is required. So I think.
So I suppose you've answered everything very cleverly and very well. It has to go through it has to be routed through the bank. The level 1 clinic cannot do anything with that semen. The donor has to go to the bank, even though he's a relative. Everything has to be done first through the bank and then come to the clinic, level 1 clinic. So that is what it is. And then basically, now we know that we are facing a lot of issues. We've discussed most of them, and most of the doctors are very, very confused. I hope we have clarified some of the confusion, but I'm still doubtful. Most of the gynecologists are still unaware that they have to register as level 1 if they want to do IUI practice. But then one of them asks you for your suggestion, Dr. Sandeep, and what suggestion or options would you have for her then? I think partly we've answered this, but I would still want you to elaborate upon this. What options do they have?
Well, over the years, this has been going on in India as treatment by medical professions and fertility specialists for a very, very long period of time. So obviously, suddenly everything is not going to change, and we will need to give people time. And therefore, the level 1 and level 2 registration is something which is yet sinking in gynecologists' minds. But a lot of gynecologists who are not into fertility as their full-time profession are finding it obviously difficult, 1, to even understand what the law is, and 2, to be able to practically implement those implications of the law. So people like us obviously have that opportunity to help them understand that the government can decide to make it very difficult. If they do, then serious implications will come, because not knowing the law cannot be a justification to not comply with the law. So unfortunately, That's not happening. So today's webinar is a big help, I'm sure, for a lot of gynecologists to clearly realize that they can't be doing what they were doing all these days, and it won't go unnoticed, and if serious actions can come. So then to summarize that part, if they decide to go ahead, like I was trying to complete that time, it was just that they can either refer the patient to us, or they can actually be cooperate with us, and we will support them in an association, or of course, they can take a level 1 registration. I'm sure a lot of gynecologists who are very caring for their patients will find it very difficult to set up a service of level 1 and be able to give the best results. I know gynecologists who are fed up, who are tired, they don't get results sometimes and they don't like it. So obviously patients they have to face all the time, and that will be counterproductive. So I think ultimately Nova, there's a national leading chain, can partner and help. Now that there is a law in place, now that there's a structure in place, we can actually design training activities for all the gynecologists and do a service to the country really by helping to implement this ART Act, and of course, helping our infertility couples.
So this is the gist of it. Level 1, only IUI. Level 2, IVF and ICSI and surgical procedures. ART banks to store all the reads. And of course, when you have none of these, you associate with level 2. That is what Dr. Sandeep has said, and that is the crux of the matter, that you do have to partner with somebody if you can't do it yourself. And that is very important. Otherwise, you will not be able to practice infertility at all. So now I think just let me give me a break. I think we have a lot of question answers over there in the question answer box and as well as the chat box. Let me ask Mr. Selvam. Mr. Selvam, are we going to answer all of them? Do we have time?
Yes, ma'am.
Okay.
Yes, ma'am. Maybe quickly,
So
15 of them are there. Yeah.
So this is basically what Dr. Sandeep had just said. Level 1, register, or you can attach to level 2, or you can refer to level 2, or stop doing IUI completely. It's the same thing. But then poor practices will have to stop. Good outcomes are definitely required if you want to move ahead in this country. So thank you. This is this of course is about Nova. So I shall start taking the questions over here now. Unexplained infertility for 2 years. It's direct IVF according to the NICE guidelines, I suppose. Well, that was a long time ago when they said either you do just contact and then go on to IVF if nothing happens for 2 years. But now, yes, there has been a lot of this thing, hullabaloo about it, and IUI has come back again, even in the NICE guidelines. As Dr. I think Rohit suggested that you do the IUI and then go on. Anonymous attendee, again, a NICE guideline says no to HSG if there is a history suggestive of tubal block like previous surgery, STI, etc. Anybody from amongst you who will answer this? Dr. Aviva? NICE guidelines say no HSG if there is no history of suggestive of tubal block.
Yeah, I would still think that, especially with long-standing infertility, first of all, if you're even going to consider doing an IUI, tubal patency tests should be done.
Dr. Sandeep, he wants to say something.
Yeah, about HSG, I have my reservations because I've heard those feedbacks from patients about how torturously painful it can be sometimes. So if in case we are looking for the tubes, then saline sonography probably is a better option in that case. Is what I just want to add.
Okay, so basically, but something to do with the tubes is essential because it may not be the same in the UK where NICE guidelines came about, but here with tuberculosis being rampant, we do have to look at the tubes before we start doing multiple cycles of IUI. So Dr. Arunesh Arora, a patient is not intelligent enough to understand every time, and the fixed notion of people about all the process is another factor. Can we guarantee them without any part of the process? I don't understand what he's trying to say. Patient is not intelligent enough to understand every time. And the fixed notion of people about all the process is another factor. So can we guarantee them with any part of the process? No, we cannot guarantee them with any part of the process. We all know that infertility is relative, and basically the treatment is also dependent upon what the factor is actually. Then accordingly, you have to counsel them. Rubina says low ovarian reserve, age 35, irregular cycles, known hypothyroid, MH is less than 1. Who is that? Aswati, would you like to take that one?
Yes, ma'am.
Low ovarian
Ma'am,
reserve,
in this,
835, irregular cycles, known hypothyroid, and AMH less than 1.
I would like to counsel this patient at the outset that when the AMH is low, it is not mandatory to do any kind of procedure, but we have to keep the time to conception very short. So keeping that in mind, I would probably not try for more than 2 or 3 cycles, be it with IUI or be with ovulation induction, and then take her up for IVF directly. Or if the patient is willing after the end of my counseling to directly take up for to be taken up for IVF, I wouldn't discourage her because I think that would be the most ideal scenario in my opinion.
Dr. Rohit, you have been the longest in Nova. What would be your approach to this problem? Low ovarian reserve, age 35, irregular cycles, AMH less than 1.
Yeah, counseling, as was pointed out, counseling is number one. And once we've counseled, then I personally would not have performed an IUI, but if the couple is insistent, we would do an IUI and then proceed with an IVF.
Sure.
By far, the counseling, what it does is it helps the patient or the couple make a choice between whether they are okay with the donor gamete or not. It should never be imposed from my side, is what I've learned working with Nova.
Okay. So basically counseling. So the next question I think should be Dr. Yogesh Thackeray. I think you can communicate with one of us and you can get an answer because this is a little longish answer. How to treat thin PCO patients for IUI? How much tablet estrogen is useful to increase the IUI output? I think we can take it separately one-on-one. You can write to any one of us. We shall supply you with the numbers and you can write to us and we can answer this. Nirvati Hospital, options for persistent thin endometrium. Again, it is a very long question, but anyway, would anybody want to give a brief answer to this? Sandeep, would you like to try that one?
Well, there are various reasons for a thin endometrium. Obviously, proper workup and then evaluation, sonographic assessment, and ultimately with estrogen therapy to see how far we get, and then they get into the treatment. Yep, we need to probably give high dosage of estrogens. There are these GCSFs and other ways as well. But yeah, I mean, there are a lot of, these are difficult cases sometimes.
It's a whole lecture, it's a whole seminar. So let's talk about leukocytospermia, general tuberculosis in males. I think I'm going to address this to Dr. Sujatha. Is there some way that we can clean the sample when there are a lot of pus cells in that and take it up for an IUI?
Ma'am, actually, density gradient centrifugation followed by a swim up would remove most of the contaminant cells. But still, we need to think whether we can inseminate this sample back because, you know, like it's just not the pus cells. It could be associated things which would be there still sticking to the sperm, which can cause infection. But to the question, yes, density gradient centrifugation would clear most of the WBCs and round cells.
Absolutely. And we know that it is sterile. Most of this leukocytospermia is going to be sterile in such patients.
Ma'am, I saw another question where somebody had asked, what is the equipment required for a level 1 clinic?
Okay.
And I was just thinking about that because the equipment mentioned in the ART rule is microscope, centrifuge, and a refrigerator.
Yes.
So that is good enough for a semen analysis. But if you have to do a semen preparation and anything which goes inside the body, I think it should be prepared in a sterile cabinet in a sterile way. And laminar airflow is a must. Though it is not mentioned there, it has to be there.
Okay, that's very important. Thank you very much. Thank you, doctor. Thank you so much. The role of BMI in IUI. Ajantha, you've been very quiet. Can you take that answer? Role of BMI, obesity in IUI. You have a patient who has a BMI of 32. Would you like to do a IUI in that case, or would you like her to lose weight first and then come to you? So Rohit, can you answer that one?
No, there's again a need versus a desirable situation, as Dr. Sujatha said. Funnily, Dr. Sujatha, just to mention this, the ART bank needs a LAF, but the level 1 does not need an LAF.
No. They don't need a technician even. I don't know what
need a technician as well,
I don't know what they have said, which is really funny. Yeah.
So BMI has to be corrected if you have the time and inclination. Otherwise, BMIs do not impact pregnancies in that such. Of course, the outcomes may not be so good, but getting pregnant is not impacted by BMI.
Okay. So basically, we have someone who is Radha, and she's during her fellowship in reproductive medicine. She was taught semen analysis and semen preparation, and I have learned everything thoroughly. And 3 cheers to you, because she says I will be able to do everything in my level 1 clinic. I think Radha, we need more gynecologists like you, and we want such things to happen. That is the only reason that this regulation has come in. And then coming back to the question before that, can semen analysis be done at level 1 clinic, Dr. Sujatha? Surely we can, isn't it?
Yes.
And here is a living example. Here is a gynecologist who says she's learned it and she's doing it. So very, very good. Can stimulation be done at level 1 and sent to level 2 for pickups? We are talking about IUI, my dear. You can do a level 1 stimulation and send it to us for IUI as well as pickups. Vandana Grover, how to get trained technicians for an IUI lab? Dr. Sujatha, how do I get? You can send your technician to Dr. Sujatha. She'll train this technician for you. Yeah, lies with Nova, and you'll get the technician.
Yes.
Right?
I think we have done it for several of our referral doctors, where, like we take them to our lab and we kind of show them the semen preparation techniques. And then we kind of give them some idea about what needs to be done and how it's to be done and all that. So definitely we can help.
So the next webinar on IUI has to be on lab techniques now, Dr. Sujatha, get ready. Okay, Anita Rajoria, she's a very prominent gynecologist from Delhi. What about registration of government gynae specialists in hospitals doing fertility, basic fertility work? What if they want to do an IUI? I don't think that's difficult, Dr. Rajoria. You have to just apply and get a certification as a level 1 clinic. You'll certainly be able to do it. How to register as level 1 doctor in Hyderabad? I don't think that Nova Hyderabad can help you, Dr. Odi, to get that registration in Hyderabad. We don't have any consultant here who is working in Hyderabad, but definitely Nova can help you over there. Want to be associated with patient as per patient's requirement? Surely you can do that. According to the ART Act, is the quarantine period of 6 months of cryopreserved donor semen mandatory, Dr. Sujatha? According to the ART Act, is the quarantine period of 6 months of cryopreserved donor semen mandatory?
Yes.
In the Act, it is not saying
Not
so.
mentioned.
Yeah, not mentioned in the Act, but it was mandatory in the ICMR guidelines. So we are still following that. I think it is essential. Somehow it has been missed. I think because, they are more concerned about chlamydia, but they haven't talked about this. So I think this is very important. From the Dr. Satish Kumar, where do we stand regarding donor semen? I think we have answered this question about donor semen. Okay, so can stimulation be done at level 1? This also has been answered. Shivani, are patients being counseled for OHSS adequately before ovulation induction in a general gynae clinic? Is that covered in the ART Act? Who's going to take that? Ashwati, take that. Yeah.
Yeah. Ma'am, earlier you asked me whether, I would be okay with the gynecologist giving gonadotropins at her clinic. I would beg to differ, because if I'm a practicing gynecologist, I wouldn't take that risk if I'm just giving her drugs and not doing the scan by myself or sending to a different ultrasound unit for scan. Because administering gonadotropin could be a risky proposition where OHSS is concerned. And I would like to protect myself as a gynae, if I'm a practicing gynecologist at all levels, because OHSS could be considered as medical negligence if not managed well.
Absolutely.
So then in that case, I wouldn't administer gonadotropins at my clinic. And of course, if I am doing it, I better do the scan myself and counsel the patient very much adequately about the implications and the probability of a OHSS happening.
Yes, absolutely. Very, very true. And what we also must remember is that all ultrasonologists are not gynae ultrasonologists or infertility ultrasonologists. They may be very good as ultrasonologists in obstetrics and in other subjects, but they may not be knowing anything about infertility. So you have to be very selective as far as your ultrasonologist is concerned also. In routine semen analysis, if it shows leukocytes for more than, we have already done this, I think, and we finished with leukocytosis. Altruistic donor semen, how to follow 6 months quarantine for cryopreserved semen, because the time will not permit. Why shouldn't the time permit? Because basically you've taken the sample, you can quarantine it for 6 months and then use it. Why shouldn't the time not permit? Am I reading it correctly or am I not interpreting it?
Correct.
Perfect. No? Okay, so we have another 20 at the chat box. My God. 1 minute. Post question. Would like a link of level 1. Doctor, yes, certainly you will get it. So some people are saying we are fantastic. Thank you very much for that, for appreciating us. How much staff will be required for an IUI? How much staff will be required for an IUI? You are a center manager, Rohit. Why don't you tell them?
No idea. There is a need and a necessity.
Sandeep, what about you?
Basically, we need one gynecologist for sure, and then of course a reception and maybe a nurse to assist. Depends on the workload. If you've got 15, 20 IUIs, you'll probably need 3 nurses. But if just 1 or 2 or 3 IUIs, then it wouldn't be much.
From where will level 1 registration be done? Is it from the PCPNDT department? It is varying from state to state. Wherever you are living, Priyanka, please check out your own state and you will get to know where registration is going to take place. It will be the same where level 2 is being registered, same office. In all donor samples, is it a must to freeze? Dr. Sujatha, all donor samples, is it a must to freeze or can we use them fresh?
No, see, actually the law says the donor sample has to come through the bank. And anything which comes through the bank is a frozen sample. I don't think we can get any fresh sample from the bank. So that kind of answers like it has to be frozen. And then this quarantine is also there, like you have to have the quarantine period.
So this is a very interesting question for our managers. What about the town where Nova doesn't have a center? How can you help us there? Yeah, well, Mr. Salvam, you should be answering this, but definitely we'll open a center close to your place of residence to help you, or you can come close to us.
Dr. Sonia, just a point I'll make there. In case we are not local there, then they can always come to any of our centers nearby and we can still help.
They can come there. Dr. Radha, what equipments are level? I think we've discussed this. Ovulation, Indra Sarmila. Ovulation induction with oral reg and injection can be done by a gynecologist. We've addressed this. Is there any drug to increase the AMH? I wish there was. Can we stimulate the patient at our center without level 1 registration and do an IUI at level 2 clinic? Again, we have answered this greatly. I won't go into the details. Patient 25 years, AMH 1.3, AFC 3 to 4 in each ovary, previous 2 abortions at 5 weeks. Other hormones on day 2 are normal. Semen analysis normal. How should I go about with this patient? Who's going to take that? Sandeep, you are right. You're right next to me. You tell me this.
Yeah, I think it was what I heard was young patient, 20.
Yes, 25. AMH 1.3.
Yes.
AMH is a little low for her age.
Yeah.
And count is also low.
Yes. There are miscarriages. There are so many reasons, really. So obviously a proper workup. If 2 pregnancy losses have happened, then a proper thorough workup, including karyotyping and of course other tests will be done. I might have a little inclination towards considering a hysteroscopy as well. Now, this is a tough one because there are so many possibilities that if your sonography is showing some hint in that direction, or there are any other pathologies, then of course a laparoscopy, hysteroscopy becomes one of the things. Yes, I know the question is hinted in a way, would you consider IVF? Well, young patient with 1.3 AMH, if the AFC is good, we may want to push back IVF, but keeping a close eye on the AMH, maybe 3, 4, max 6 months that you can try and do something for her. If not, then IVF. This is a proper thorough counseling, I think we need to take a whole overall picture as to what she thinks and so many other factors. But yeah, 6 months maximum because she's young, then give it a try.
Okay. 29-year OPD thin PCO lady with childhood pulmonary COX, MON2 positive, tubes patent on HSG 2 years back, failed with letrozole. How to proceed? Rohit?
Send them to Dr. Sandeep for a pelvic evaluation.
Absolutely. Let's do a laparoscopy and then see what's going to come out of it and then decide. Okay. Radha, to us, while doing fellowship in my madam taught me, we've done this. Archana Saste, are you giving any training for level 2 semen analysis labs? Yes, Dr. Sujatha is giving training. Please get in touch with her. She's giving training for everything. Bubbly to host, how do you go in for surrogacy? We're not discussing it today. time between processing of semen sample and IUI procedure, how does it affect the success rate? Very important. Who was talking about this out of you? Rohit and Sandeep were both talking about it in terms of traffic and what also. Rohit, you take it and then Sandeep can take it.
I think I'll pass the ball to Dr. Sujatha because she has to explain this. And this is very important. I think this is the most important point that I would expect Dr. Sujatha.
All right. Sujatha, then the ball is in your court. You start telling us time between processing of semen sample and IUI procedure. How much are you going to batter the clinician to do it quickly if she's not attending to you after you've prepared the semen?
Okay, so the rule of thumb is never leave any gamete outside the body for a very long time. The sooner you can get it back into the wherever it belongs to, it is better. So that's the rule of the thumb. Now, there are so many things here, like you cannot just say that within 15 minutes, within 20 minutes, it all depends upon the concentration. For example, if we have prepared a sample which is very high in motile sperm concentration, leaving it outside, though it must be a very good sample, leaving it outside for some time, it actually, like the sperm would use up all the nutrients in the media, and then wherever it has to go and fertilize, it will not be able to do it. So it depends on the concentration, it depends on the motility, it depends upon the quality of the sample. Just to give you an idea, see, we used to do a lot of this sperm survival assay. And when we do sperm survival assay, the concentration which is recommended is 2 to 5 million per ml. So if you have such thin concentration, then the sperm will survive outside the body, say for 24, sometimes to 48 hours. But suppose if you are having an IUI preparation, you are having close to 20 million per ml, then you can't leave it outside for a very long time. It has to actually be inseminated. So the thing is, rather than going by the time, it's always better to think this way. The moment the sample is prepared, the earlier you put it back, it is better. And if you are not able to do it, it is, the studies say that it is better to keep them at room temperature rather than keeping them at 37 degrees Celsius. If it is going to be a very short time, 37 is fine. But then if it is going to take an hour or so, then it is better to keep at room temperature for some time on the laminar airflow and then inseminate it. I think
just to add one thing there, in a way, keeping it longer outside is definitely not going to add value to our treatment, obviously. So to look at the other way, the earlier the better.
The earlier the better, yes. So
ideally 90 minutes, I guess, from time of collection
exactly.
to
Exactly.
90, not more than that. Anyway, can we personally do IUI at level 2 clinic? Our clinics, yes, or the IVF doctor only can. If you are registered with us as a level 1, you can certainly do it. Okay, persistent moderate free fluid in the POD, PID, treatment given but not resolved, ultrasound normal study. What do you want to do? What would you want to do? Who's here? Dr. Aviva, would you like to answer that? Where is she gone? Is she
I mean, after you've maybe given them a course.
They haven't mentioned when. It must be afterwards only, after rupture.
After a course of antibiotic.
She's talking about PID, yeah.
Maybe this is one of those places where doing a laparoscopy may help.
Yeah, absolutely.
Ideally, if it's just a very minimal free fluid, I would ignore it.
Yes, yes. So I think that brings us to the end of our questions, as well as whatever we had in the chat box. And I think the last question is are we going to get a recording? I think Mr. Selvam will answer that. So thank you very much, all of you who've been here with us right till the end, for being with us through this webinar. And thank you very much to my panelists. I've really enjoyed doing this one. So let me just stop sharing my screen and come back to all of you. Thank you so much, all of us, for being here.
Thank you.
Thank you. It was a pleasure.
And thank you, panelists, and thank you for all the doctors who have been participating very actively. I think the kind of questions and the number of questions is also giving us a lot of insight, the interesting among the gynecologists. And as we been in the progress of a webinar, like of course, like Dr. Sonia ma'am said, could be a laboratory equipments in an IVF. I mean, IUI could be another topic for the webinar. And another interesting topic came like role of laparoscopy and endoscopy in IUI. Could be another topic for us in the forthcoming webinar.
Yes.
And as a part of Nova academic event, where we are always been in the forefront in engaging with our referral community doctors, In the next 4 to 5 weeks time, we will be floating about another interesting webinar. And please do keep in touch with the Nova marketing team, where they will be able to connect with you with all the record things. And I see the last question where the recording is available. Definitely the recording is available. Please do get in touch with our Nova marketing team. And thank you so much once again to all of you. And we will see, we will see you soon in another interesting webinar.
Dr. Rohit wants to say something.
No,
Yes,
just one point. I think
Yes,
a special thanks flows out to Sonia Madam for shepherding us so well.
Yeah.
It was a
Yes,
wonderful,
yes.
well-flowing session, and it's a good
Thank you.
time we all had.
Actually, I think we've all enjoyed, and I'm now looking at the chat box.
Really.
I'm really, really happy to see so many thank yous over there. So I think it was worth it. We all did well. Thank you so much. Thank you so much.
Thank you, ma'am. Thank you.
Thank you.
Thanks a
everybody.
lot.
Thank you.
Sujatha, your inputs were really very, very important for us. Thank you so much.
ma'am. Thank you, ma'am.
Thank you.
everyone.
Thank you.
Bye.
Bye-bye.
Till we meet again.
Yes,
Bye.
Yeah,
thanks a
great.
lot.
Yeah. Good.